Welcome to The Explainer. Today, we're looking at the invisible architecture that literally holds up our entire healthcare system. I'm talking about medical coding and billing. Now, I know to some people that might just sound like endless paperwork, but in reality, this is the structural blueprint of healthcare revenue and clinical integrity. Without it, the whole system just crumbles. So today, we're going to decode exactly how clinical work gets translated into the universal language of healthcare.
Okay, let's dive into this and walk through our structured four-part roadmap for today. First, the languages of healthcare. Second, mastering EM service levels. Third, the risks, downcoding and fraud. And finally, essential diagnostic coding rules. So whether you're a coder, a clinician, or a clinical documentation integrity specialist, stick with us because we are breaking down the absolute fundamentals today.
All right, moving right along to Section 1, the languages of healthcare. Decoding CPT and ICD-10. Because, before we can actually build a sound medical claim, we really need to understand the two very distinct languages that make it up. Let's break these down. First up, we have CPT codes, or current procedural terminology. These are maintained by the American Medical Association, and they're basically 5-digit numeric codes, there are about 7,800 of them, that document the exact procedures and services provided. Think of CPT as the what. Like, what did you actually do for the patient? Then, on the flip side, we have ICD-10 codes. These are maintained by the World Health Organization, and wow, this is a massive system. We're talking over 155,000 codes that classify diseases and establish the medical necessity. So ICD-10 is the why. Why did this patient need to be seen today? Ultimately, a successful claim requires a flawless translation between that what and that why.
Let's roll right into Section 2, Mastering EMM Service Levels, the core calculation. This is the second phase of our blueprint, where a patient encounter turns into a really precise mathematical calculation based on very specific clinical inputs. Now, what's really interesting about this slide is how EM complexity breaks down into 3 core pillars. To figure out your level of service, you have to look at the history, the physical examination, and the medical decision-making. Your history includes the history of present illness, a review of systems, and past medical, family, and social history. Then, your physical exam is graded on its overall scope and complexity. And finally, medical decision-making. This one weighs the number of treatment options, the amount of data you had to review, and the patient's risk for significant complications or morbidity. Your clinical documentation absolutely must clearly support every single one of these pillars to justify the complexity of the service you're billing for. But wait, there is a dramatic exception to this 3-pillar rule, and it's a big one: greater than 50%. If face-to-face counseling or coordination of care takes up more than 50% of the total patient encounter, time suddenly becomes the controlling factor for your EMM level. It literally overrides the 3 key elements we just talked about. You just have to clearly document the total length of time of the encounter and then describe those counseling or care coordination activities that took up all that time. Okay, we need to shift gears for a minute and apply a serious stress test to our coding blueprint. This brings us to Section 3, the risks, downcoding, and fraud. Let's look at the severe financial and legal stakes of inaccurate documentation. A massive risk in our blueprint here is downcoding. Downcoding happens when an insurance company comes in and actually reduces the value of a procedure and your resulting reimbursement because of a structural failure in your documentation. This usually happens when there's a glaring mismatch between the CPT code and its description, or when the ICD code just completely fails to justify the level of service billed. Put simply, if your what and your why don't perfectly align, lost revenue is the direct, unavoidable result. So the crucial point is captured perfectly by this medical legal alert from our source material. Listen to this. Although getting paid is a very important issue for healthcare providers, you should never code for reimbursement purposes only. This can be construed as fraud. That is a stark warning. The very second you start manipulating codes just to boost reimbursement without real, genuine clinical justification, you're crossing a major line. You go straight from poor documentation into actual billing fraud. Your codes must always reflect the honest, documented truth of that patient encounter. Let's transition into our final section today. Section 4, Essential Diagnostic Coding Rules, the Masterclass. I promise you a rapid-fire masterclass here on the golden rules of diagnostic coding. These are the rules that will actively protect your organization from those exact financial and legal risks we just went over. Let's walk right through the first 3 foundational rules for assigning your diagnostic codes. Step 1. Tests must correlate. Any test you order absolutely has to associate with an ICD diagnosis.
You can't just go ordering a test without proving the medical necessity for it first. Step 2, specificity is king. Always, always assign the most specific diagnosis known at the time. Don't fall back on a generic code if you actually have the clinical data for a highly specific one. And step 3, primary versus secondary sequencing. Your primary code has to reflect the chief complaint, the main reason for the encounter. Your secondary codes are then listed to expand on that and show the true, full complexity of the visit.
And this brilliantly illustrates how you capture the full clinical picture. You need to code chronic conditions as often as they apply to the current condition. You also absolutely must code coexisting conditions that influence patient management or outcome. For instance, if a patient is dealing with depression, that might significantly affect how they perceive something like abdominal pain, making their overall care much more complex. Finally, when a condition is described as both acute and chronic, you code both. But remember, you always list the acute code first. Now, here is a firm rule that trips up a surprising number of people. There are literally no rule-out codes in outpatient final diagnosis coding. None. You simply cannot code rule-out appendicitis as a final diagnosis on a claim. There's no code for that. If you haven't confirmed a diagnosis, you must instead code the known diagnosis, symptom, condition, or problem, like right lower quadrant pain. Always stick to what is definitively known. And our final rule for this masterclass: do not code routinely associated signs and symptoms separately. Never unbundle symptoms that are just naturally integral to a disease process. Take an upper respiratory infection, or URI, for example. A URI naturally encompasses symptoms like pharyngitis, rhinitis, and a cough. You do not code all 4 of those things separately. You use the single URI code because it inherently includes all the rest of that. Basically, keep it bundled and keep it clean. So as we wrap up this explainer, I want to leave you with this final thought. Are your clinical building blocks structurally sound and legally compliant? Because remember, mastering the alignment of CPT, ICD-10, and EM guidelines isn't just about getting paid. It's really about accurately reflecting the incredible care you provide every single day, all while protecting your clinical integrity. Please like, share, subscribe to Decode Healthcare with Harsha.